Hello students, welcome to EPG Pathshala. I am Satwanti Kapoor from Department of Anthropology, University of Delhi. Today we shall be discussing on maternal and child health from the paper Applied Anthropology. The learning outcome of this module are to study maternal and child health and the factors associated with the same. First of all, we will discuss briefly about the definition and background of maternal health and child health, MCH. It's abbreviated as MCH. Motherhood and childbirth is a time to celebrate new life. Yet this miracle of birth leads to masses of unnecessary deaths every year due to inadequate health care. Maternal and child health is the professional and academic field that focuses on the determinants, mechanisms and systems that promote and maintain the health, safety, well-being and appropriate development of children and their families in communities and societies in order to enhance the future health and welfare of society and subsequent generations. MCH should be considered as a profession rather than a discipline. It is an umbrella concept. It is a dynamic field that aims to improve the health of women, children, youth and entire family and hence the communities while addressing health inequities and the systems and policies that contribute to family health, women's health across the lifespan, sexual and reproductive health, the perinatal period and birth outcomes, interconception care, child health including mental health and special needs, adolescent and youth developments are some of the many maternal and child public health challenges. This work uses a life course perspective to address these issues, combining an understanding of human development and the social determinants of health as they accumulate and interact across the lifespan and across generations. The Southeast Asia SEA region accounts for more than 1,74,000 maternal and 1.3 million neonatal deaths every year. It's a very high number, which is approximately a third of the global burden. This region also accounts for 1 million stillbirths and 3.1 million deaths of children under 5 years of age annually. Bhutta and Black 213, WHO 213. Thus, the SEA region faces a great challenge in reducing maternal, newborn and child mortality as integrated in the Millennium One development. Globally, maternal child mortality are in decline, although the pace of decline is not sufficient to attain Millennium Development Goal MGDS 4 and 5 for 128/137 developing countries. Now this figure here shows the global maternal and child health MCH priority countries developed by US government. Due to slow progress in reducing infant and maternal mortality and the moral urgency of reinvigorating efforts to tackle slow progress, the United Nations UN launched the Global Strategies for Women's and Children Health in 2010. As part of this strategy, India committed to spend US $3.5 billion annually for strengthening maternal and child health services in 235 districts, which accounts for nearly 70% of infant and maternal deaths. Bhutta and Black 2013, WHO 2013. Now, what are the indicators of MCH? Let me tell you. According to WHO, there are 11 indicators of maternal and child health, which are as follows. Maternal mortality ratio, children under 5 years who are stunted, under 5 child mortality with proportion of newborn deaths, skilled birth attendant, met need for contraception, antenatal care coverage, postnatal care for mothers and babies, antiretroviral ARV, prophylaxis among HIV positive pregnant women to prevent HIV transmission and antiretroviral therapy for pregnant women who are treatment eligible. Next, 3 doses of combined diphtheria, tetanus, pertussis, DTP3 immunization coverage 12 to 23 months. 10. Exclusive breastfeeding for at least 6 months. 11. Antibiotic treatment for suspected pneumonia. Now, maternal mortality ratio. Maternal mortality ratio may be defined as the number of deaths from any cause during pregnancy or within 42 days of its termination, irrespective of the duration and site of pregnancy per 1 lakh live births. Now, depending on the standard of maternity care or the extent of its availability and acceptance, this mortality rate varies. Maternal mortality may be due to direct causes such as complication of pregnancy, labor and puerperium, indirect or associated causes such as aggravation of pre-existing diseases like hypertension, diabetes or anemia, or unrelated causes such as traffic accidents, intestinal obstruction or cancer. Deaths due to direct cause, also called true maternal deaths, are mainly due to sepsis, hemorrhage, toxemias and accidents of labor including rupture of the uterus. Now the figure illustrates the maternal mortality ratio. There are other factors which influences maternal mortality, and these are place of delivery. Over 90% of maternal deaths occur in home delivery or emergency admissions. Reproductive efficiency is highest at 21 to 25 years. In teenagers, the risk is slightly higher. In women over 35 years of age, it is 3 to 4 times greater. After 40 years, it is 6 to 10 times more. WHO 1977. Third is parity. It is safest with the second or third delivery. With primipary, the risk is slightly increased. With grand multipary, it is 3 times more subjected to hemorrhage, malpresentations or ruptured uterus. Fourth, social class. Maternal mortality is 6 times higher in poor and the unskilled than in wives of the marginal groups. Lowell-Jones 1974. This could be explained by the poor nutritional status and lack of antenatal care in the former. Fifth, other factors. The risk of maternal death is greater in single women than in married women, in rural areas than in urban areas. Anemia is responsible for 20% of maternal deaths in developing countries, mainly due to congestive failure, shock, sepsis or thromboembolism. Such women are poor risks for any operative delivery or anesthetic procedures. Maternal health services. Antenatal care. Antenatal period is best time to provide the mother with necessary health related information and even interventions if required, which leads to their better health and survival along with the infant. UNICEF 2008. Maternal and neonatal morbidity has been shown to be reduced because of many antenatal interventions. Antenatal care can be defined as a care a woman gets during childbearing which helps and ensures the healthy outcomes for both mother and her infant. WHO has recommended 4 minimum antenatal visits for lowering risks during pregnancy. Antenatal care may not necessarily prevent the complications from occurring but lower the risk for maternal death and could provide enough time to cope up with the complication. Many of the thousands of mothers could save their life if proper medical care and appropriate health management system is provided. Singh and Yadav 2000 found that 9% of the pregnant women had at least one antenatal visit while 62% of them had 3 or more antenatal visits, while 11% of the women did not visit for antenatal checkup even once. For antenatal visits, there is a huge gap in access for urban and rural women. According to NFHS 3, 91% of the women in urban areas were having access to antenatal care as compared to 72% of women in rural areas. Also, a direct association was found in NFHS 3 between antenatal care access and education. 85.3% of women with 10 years of education, 67.3% of women with 8 to 9 years of education, 59% of the women with less than 8 years of education, and 29.8% of women with no education receives antenatal care. Now we will speak about delivery care. Maternal care is considered as a social event as much as a medical phenomena where access and use of maternal health care services are influenced by social contextual factors. Traditionally in India, pregnancy is considered to be a natural state of being a woman and not a condition which requires medical attention and care. These perceptions and beliefs create a lay health culture which acts as an intervening factor between presence of morbidity and its corresponding treatment. Such lay health culture apparently has substantial effects on the utilization of maternal health services in regions where poverty and illiteracy are widespread. To achieve reduction in maternal mortality due to two challenges, first is to obtain skillful services by a birth attendant during labor and delivery. Secondly, to access high level of obstetric care in case of complications. To meet these challenges, competent health professionals and an environment in which these health professionals can perform effectively is much required. Most of the childbirth in all developed countries and in many urban areas of developing countries take place in hospitals with skilled birth attendant. On the other hand, most of the childbirth in rural part of developing countries took place at home without any skilled birth attendant and generally with poor access to medical care. Researchers have attempted to measure and identify factors affecting the use of maternal health services. From the date of NFHS1, analysis was done to look for factors affecting the use of maternal and child health services in rural part of 4 northern states, and it was found that socio-economic factors like education, standard of living and media exposure creates a demand for service and is affected by availability and physical access to health services. Das et al. 2001. Majority of the research have stressed on the role of demography and socio-economic factors which influences the utilization of and demand for maternal and child health services. Now we will talk about postnatal care. Mother and their child need to be cared beyond time of birth and also throughout postpartum period, which extends until 42nd day after delivery, a period which is unfortunately ignored by many as per UNICEF 2000 days, as there is the highest risk for both mother and child during childbirth or immediately after birth. Hence, it becomes critically important to ensure appropriate postnatal care to safeguard newborn and mother. More than 2/3 of deaths of newborn occurs within first week of birth, and out of those, most of the death occurs within 24 hours of delivery. Lawn et al. 2005. In India, almost 39% of newborn deaths occur on the first day, while around 57% occurs between first 3 days. Maximum of the maternal deaths occur between third trimester and the end of first week after birth. Only promoting antenatal care, institutionalized delivery and skilled attendance at birth is not enough to promote maternal and child health. Postnatal care for all mothers and neonatal should be recommended with special reference to low birth and small babies. Despite government initiatives and policies, there has been a lack of follow-up after childbirth. Furthermore, mothers only seek postnatal care during complications after birth. Poor knowledge, lack of schooling, poverty and insufficient services of follow-up in healthcare system prevent women to seek postnatal care. Now we talk about immunization. The pregnant mother and her newborn should be protected from infections. Now, immunization of all prenatal women with tetanus toxoid is a routine procedure throughout the world to prevent puerperal and neonatal tetanus. The EPI, that is Expanded Program on Immunization, was introduced in 1974. This program covered 5 vaccine preventable diseases, that is tetanus, tuberculosis, diphtheria, poliomyelitis and pertussis. The UIP Universal Immunization Program came into existence in 1985 to 86, in which vaccination for measles has been included. In 1992, this program became a part of the Child Survival and Safe Motherhood Program, CSSM. Then the Reproductive and Child Health Program was introduced in 1997, which was targeted to cover all the pregnant women with tetanus immunization and also infants with primary immunization. All the cold chain equipment and the vaccines are supplied by the central government free of cost. Also, vaccines are given to all the beneficiaries at every immunization session free of cost. The surveillance of vaccination preventable disease is done by visiting homes and OPD and IPD cases. The main objective of the immunization is reduction in maternal and infant morbidity and mortality because of vaccine preventable diseases. At present, elimination of neonatal tetanus, NNT, measles and eradication of poliomyelitis are important objectives. These vaccinations have been done under the supervision of some health expert. The schedule recommended by Government of India is followed during the program. The primary aim of this program is to immunize at proper age with proper dose and appropriate route before first birthday of the child. Family planning. It's another important component of mother-child health. Family planning has been considered as the most effective way of controlling massively and rapidly growing population. WHO 1971. Family planning is an influential factor in controlling maternal mortality level by decreasing total number of births and the number of unwanted pregnancies. In developing countries, programs to promote family planning initiated in 1960s in response to improvement in child survival, which ultimately led to population growth. Cleland et al. 2006. Since the inception of the program, fertility levels in India has been declined with varying paces at different regions. The total fertility rate reduced from 6.4 to 6.6 lifetime births per woman in 1970s to 3.4 lifetime births per woman in 1990 and 2.68 found in NFSH3. India is moving slowly but steadily towards goal of replacement level of fertility, decrease in birth rate and increase in contraceptive prevalence. The most common reason responsible for unmet need of family planning are lack of information, unsatisfactory or inconvenient services, and fear of side effect of contraceptives. Opposition from partner, family and others. There is an interrelated complex of factors which affect the use of family planning. For instance, women's status, educational level of the women, employment of women, involvement of political activity and mobility and autonomy. Now this figure illustrates the contraceptive need and use globally. It shows that in developing region 38 million adolescent women need contraceptives to avoid an unintended pregnancy, but around 60% are not using modern contraceptives. Now STDs and RTI. Worldwide reproductive tract infection RTI, including human immunodeficiency virus HIV, continue to be a serious public health concern. Many men and women both are affected from reproductive tract infection RTIs, along with sexually transmitted infections which are called STIs. Around 340 million new treatable cases of STI befall each year, with approximately 151 million cases of them in Southeast and South Asia region. Prasad et al. 2005. STIs are considered among top 5 categories for which individuals in developing countries seeking treatment or health care, and 1/3 of STI occur in people below 25 years of age globally. Pelvic inflammatory disease, PID, infertility, cervical cancer, spontaneous abortion and ectopic pregnancies are the most serious long-term consequences in women, which may lead to maternal death later. Previous studies have reported that in Indian context, PID is more likely to be an obstetric problem in origin rather than a result of STDs. Belse 1976, Brabin et al. 1998. In India through 1990s and 2000, research regarding women's experience of RTIs along with STDs has been increased considerably. Many policies and programs like National Population Policy 2000, National Health Policy 2002, National Rural Health Mission 2005 and First National AIDS Control Program 1992 to 1999 have been launched for increasing women's access to health services for preventing, managing and screening of RTIs. For many reasons, there is a lack of information about the epidemiology of RTI in India. Situation in tribal and rural areas are worse as they hardly have any access to healthcare facilities during childbirth. So many STI and RTI goes undiagnosed or many do not have any treatment available. It became crucial to prevent their transmission. By adopting safe behavior, risk can be reduced by an individual. Encouragement of these safer behaviors should then be incorporated in programs and policies. Ravi and Ethimulam 2014. Around the world, lives of women are changing vividly in different settings. Still gap exists between the reality of women's reproductive lives and women's reproductive hope. Now let's summarize the module. Maternal and child health care is central not only to the immediate objective of improving the health of mother and child, but also to the broader of objectives of optimal human development and lifelong individual and community health. The health facilities for mothers and children must be available to the majority of the population. This can be accomplished best by comprehensive planning to distribute resources according to needs rather than the ability to pay. MCH should be considered as a broader aspect which covers all the necessary points. These health functions are best handled as an integral priority of general health services focused on basic human needs. In some peripheral areas, because of their priority, MCH and/or family planning activities have developed initially as isolated services. When other services are developed, integration with MCH as a nuclear service avoids wasteful duplication and fragmentation. Where general health services are already in place, they must devote adequate attention to maternal and child health priorities. A wide range of cultural, religious and political attitude influence maternal and child health concern, and the status of women is of particular importance. Thank you.